It's great. Thanks very much, Mike. And that methodological work is so important. Thank you. So now we have Professor Krish Nirantharakumar, Professor of Health Data Science and Public Health at the University of Birmingham and co-I of Optimal. Thank you.
Hi, everyone. I'm Krish Nirantharakumar, very long name. I'm the co-principal investigator. Along with me, I have got Thomas Jackson, who is a geriatrician and the principal investigator. I'm mostly known as the spokesperson for this particular consortium. The hard work is actually done by Christine and team who lead the PPI here, and Jenny and team, Ellie, Marco, all the early career researchers. I just do this, go and talk. Okay, so first of all, big thank you to them. I'm going to talk about Informatics Consult, some of the work from Optimal, but also linking into other pieces of work. So the two questions we were asking in Optimal, in a person with health condition, what are the next likely health condition? And secondly, what is the influence of a prescribed medication on one, the condition it was prescribed for, the health condition that coexist, and the health condition that are predicted to occur in the future. Now, how we are doing is, of course, data, a lot of CPRD all over again, and along with some secondary care data called Pioneer, and data from Scotland. The methods we are using, of course, involves machine learning, but also more importantly, automation, which is a software we have developed here in Birmingham. When it comes to predicting health conditions, the topic I'm going to mostly focus is medicines. The first question, naturally, we know at the moment we develop individual prediction models. Here is one example from NICE for chronic kidney disease. And that actual prediction model comes from American data. And if you try to put it into a primary care in UK, it doesn't really calibrate well. And our nephrology colleagues have done good work in getting it to a level that it works well here for the UK population. But imagine if you want to predict every other health condition like this, we'll be having hundreds of RFPB grants. Okay? And if you ask Neil, who tells us 95% of prediction models never get used in practice. Okay? So can we create a foundation prediction model that will help us to predict future health condition or any future events? That was the first question. And the work is done by Professor Christopher Yao from Oxford University and Charles, who is the early career researcher who is doing this work. One of the key things, of course, many are doing foundation prediction model. One of the key things what they have done is embed it into a survival model, which they have created. And if you ask it, it can predict in the next 5 years, A, B, C, what medication they are likely to end up getting or what health condition they are likely to get. How well does it work? We'll have to wait and see. Okay, so it's very early days. Initially, we also thought, can we use AI for the second question? That is, what is the best next likely medication we should be giving? So imagine a patient, Mary, who's got existing health condition, diabetes, depression, ischemic heart disease, COPD, predicted health conditions, dementia, osteoporosis, and renal stone, currently on metformin. What is the next best likely medication that person should get to control diabetes? Let's assume there are a few candidate medications. And second question is, what are the medications that person should be following acute coronary syndrome? The first principle in this is to make use of existing good evidence. And largely, that is the most important thing, not create new evidence, based on observational data, but rather use existing good evidence in clinical guideline. For how do you do that? Naturally, when people think about medications, in this case, they'll think what will control the diabetes, then what will prevent the complications for diabetes, what effect it has on existing health condition, predicted health condition, and then patient choice as well. Now, here's a good example. This is not part of Optimal. A technology created by a cardiologist in University of Birmingham called Medicaid. This one can actually tell you which medication should be used in such circumstances, okay? And it also takes into consideration different guidelines. For example, for the same medicine, NICE will say one thing, the European guideline will say another thing, okay? So what they call meta guideline, and then at the same time, in the presence of comorbidity, what you should be prescribing. Sorry. The second example is a recently funded project by NIHR for low middle income country. So this we will be doing in Sri Lanka, where we want to create a learning health system using 3 technologies. One, knowledge to practice decision support system, practice to data using good quality electronic health records, and data to creating new knowledge, taking a technology called Dexter. Now I'll go to the medication choice again in this particular patient. Now, the difficulty here, there is no definitive answer. And clinical trials do not involve patients that have a range of multiple health conditions for us to work out which may be the best medication in such circumstances. In such circumstances, in the absence of existing trial evidence, can we do something? And this is where AI methods have been tried, in my opinion, haven't worked very well. And therefore we go on to automation. And anyone who has met me will hear Dexter again and again and again. It's an automated tool for creating pharmacoepidemiological studies or any epidemiological studies, which can do things which took 6 months within 60 minutes. I can't go into detail because I have got the first flag out there. But essentially, it's a software you can take and make use of. It's being spun out very soon, so universities and others can make good use of. But if you ask that question, it may give you these results. It may tell you for your predicted health conditions, which may have a positive effect. So it gives you information using data that you can make use to do better prescribing. It will take time for it to come into practice, but this is the way forward as we take time going forward. But it's also equally important how we present this information. And that itself is a long piece of work, and we will be working towards that. But the key thing to say on top of that is we are producing some population level tools like Marco is, for example, population level trajectories in a group of people with a particular ethnicity and age groups. What would you expect the next likely health condition could be? But also what we lack for polypharmacy is what happens if you were prescribed not 1, but 2, 3, or 4 combinations of medicine. And what happens for those 4 combinations of medicine if they are prescribed in different orders. So that type of population level surveillance tool is also being built by Marco. So you can actually visualize it and see if there is any harm, we need to be worried, but also take it as an opportunity to understand and also innovate new medication that can be repurposed. Thank you.